Hi, it's Dr. VanDyke, and I'm going to talk to you about hirsutism, which is a fancy medical word for excess hair in women. This is the handout that we wrote for our patient education library. Hirsutism is excess hair growth on parts of the body that are dependent on the activity of male hormones known as androgens. This typically is going to be the chin, the sideburns, chest, areolas around the nipples, abdomen, upper and lower, the upper and lower back, as well as the pubis and the inner thighs. Both men and women make androgens, of which testosterone is only one. Androgens can be produced in the ovaries or testes, as well as in the adrenal glands. What causes hirsutism? First of all, genetics or ethnicity. If your hair patterns are similar to your parents' hair patterns, this is probably what we would consider a normal variant. Mediterranean, African, Indian populations all naturally produce more hair than Asian, Native American, and many white populations. Hirsutism can also be caused by ovarian dysfunction. Ovarian tumors can make androgens, as well as polycystic ovarian syndrome. Patients may have adrenal dysfunction, where tumors in the adrenal gland can make androgens or cortisol. And then there can be non-tumor causes of excess androgens, such as the genetic condition congenital adrenal hyperplasia. Pituitary gland tumors in the brain can signal for excess androgen production from the adrenal glands or from the ovaries or testes. There are certain medications, such as certain types of contraceptive pills or IUDs, steroid hormones, seizure medications, and even supplements that can cause hirsutism. How do we diagnose hirsutism? Well, we have to check a patient's history of hair management. So we ask about plucking, shaving, waxing, we gauge hair growth, and we use something called the Ferriman-Gallwey score in order to do that. A score between 8 to 15 is considered mild hirsutism. If you have a score under 8, you're considered normal. Then we want to investigate a patient's puberty. Did they have puberty early? Was it very late? And what about their periods? When did they first have periods? Are they happening frequently or are they happening infrequently? We can check labs for excess androgens, and maybe we'll do an ultrasound of the pelvis. We want to check those ovaries as well. Once we diagnose hirsutism, how do we treat it? Well, number one, we always want to treat the underlying condition. So if we find a tumor in the adrenal gland or the ovary or somewhere that causes androgen production, we need to get rid of the tumor, and that solves that underlying problem. If a patient is diagnosed with polycystic ovarian syndrome, we treat this with oral contraceptives that do not make androgens worse. And there are a whole boatload of these contraceptives that we can opt for. Yasmin is an example of one that works that way. We need to be able to remove medications that make androgen production worse, so long as it is safe and appropriate. And so that means that we'll have to communicate with the rest of the healthcare team who may be prescribing those other medications. If treating the underlying condition is not enough, or there is no apparent underlying condition, then we can add medications like spironolactone or tamsulosin. And these medications help reduce hair growth in part because they can block the androgen receptors in our tissues. Various hair removal methods are available. Unfortunately, these are usually not covered by insurance, but they include laser treatments, electrolysis, shaving, plucking, waxing, and threading. So if you need more information, you can Google image search the Ferriman-Gallwey score and see some pictures about how we score that. The Mayo Clinic, of course, has a section on hirsutism, and the UCLA OB-GYN department at obgyn.ucla.edu has a page about hirsutism.